Hello, everyone, and welcome back to the Shoulders Up podcast, where we break down complex headaches and dizziness. I'm really excited to have my guest today, who is a fellow physical therapist who also specializes in treating headaches. So the guest today is Dr. Corey Hillman. He is a physical therapist in Greensboro, North Carolina, specializing in craniofacial therapy to address head, neck, and jaw pain and dysfunction. He is the owner of Gate City Physio, Headache and TMJ Care. He has advanced training in manual therapy and chronic pain management from the Integrative Pain Sciences Institute and the Craniofacial Therapy Academy. Dr. Corey Hillman, welcome.
Hey, Jimmy. Thanks so much for having me. I'm really excited to be here.
Of course. How are you doing today?
Doing well. Spring's starting to come in Greensboro, so that's always a good thing.
I see. Well, with spring also comes spring allergies, and that also translates to headaches as well. So let's dive right in. So you and I are both people who specialize in headache, but I think the link between headaches, jaw pain, and neck pain, is very apparent to us. But for those who aren't familiar, can you tell us a little more about how jaw dysfunction might fit into headaches, neck pain, and facial pain?
Yeah, absolutely. There's a couple of different ways I like to explain this. One of the more common things that we talk about is there's overlap between kind of the actual subgroups of people that are experiencing this mostly. Just like with headaches, particularly like your primary headaches like migraine that typically are kind of a 3-to-1 ratio of women to men. This happens with kind of TMJ, TMD as well. And so there's probably some genetic hormonal components that go with this, but particularly as a physio, I think about this both biomechanically. We know, from some research that, kind of that forward head posture can put some strain on the joint itself. But even more so than that, talking about this from the standpoint of neurological connections. So your audience may be familiar with the trigeminal cervical complex. This is kind of a big neuroanatomy term that we use to talk about this area in the brainstem that gets information from both the neck as well as the nerves of the face. So kind of as they're coming in together, we can often see a lot of overlap with that as far as symptoms and how that presents.
So I just want to expand beyond that, just for our listeners. What are some other symptoms with jaw dysfunction besides headaches? Right? What are some other clues that clinicians or people can listen in for that they would really know? Because I think a lot of people with headaches, most of them are going misdiagnosed for years. And I've had a lot of clients come in who were told it was TMD, and then I don't really think they show the signs. And then I've also had it the other way around where they were, where I was convinced with TMD, but they weren't convinced because they heard from maybe their primary care provider that that wasn't what it was. So what do you think are some things about TMD headache that really distinguish it from other headache and facial pain disorders?
Yeah, it's a great question. I think from the standpoint of actual TMD kind of being a big trigger for a headache, some of the classic things we see with this is if there's clenching, bruxism during the day, and that kind of leads on to a headache, as well as from the standpoint of location. They tend to be more kind of temple headaches, some into the frontal region as well. But they're often kind of brought on either by some sort of stuff going on throughout the day. So this could be if you have a job where you're talking a whole bunch, and that kind of has those progressive symptoms of I got up, I gave a talk at work, I had to use my facial muscles a lot, then I got a headache. That can be one kind of thing that often leads to that. One of the other things I see a lot with this too is is there kind of provocation with other things like chewing, laughing, yawning, and do those kind of lead into a headache itself? But there's really kind of going back to this reciprocal relationship. We know too that often these can be kind of hard to pinpoint which one is kind of driving which, particularly within our primary headaches. So this again, your tension type and your migraine headaches. Often these people will have kind of sensitivity to the jaw areas, the masseters, the temples as well. So I know we're going to get a little bit more into kind of talking about evaluation process, but this can be really key for the clinician as far as deciding kind of where to jump in from a treatment standpoint.
Yeah, absolutely. Headaches, we're both in this kind of niche field, and I think you and I both already know, as well as our patients, that, headaches and chronic, temporal mandibular disorders, TMJ, TMD, these are notoriously difficult to treat for a lot of people. So, what drew you to these complex cases?
Yeah, it's a great question. I think I'm like you in the fact that these complex cases, particularly of the head and neck, have always kind of fascinated me clinically. I think there's a couple reasons that kind of brought me into this. When I was in high school, I used to have chronic tension type headaches. almost daily. And I was, living on prescription strength, although not prescription just over the counter, but strength of like ibuprofen. I was taking that, sometimes twice a day to just try to get ahead of these headaches. And I was kind of under the impression that that was about all I could do. And even being, 16, 17, you kind of future cast a bit and think, I don't want to live like this. This is not what I'm envisioning. I'm hoping to go to college and into healthcare and stuff like that. And so by chance or serendipity, depending on your philosophical bend, I ended up getting to do a senior project in high school with a chiropractor. And somehow the topic of headache came up, and I started getting some treatment from this chiropractor. Saw some pretty, not to be hyperbolic, but pretty dramatic results of starting to take less medication, ending up getting more into kind of lifestyle components, looking at like my stress and physical activity and sleep and all these different things that we talk about, and saw a really dramatic shift with that, especially by the time I got to college and even through today. Like, obviously, I still get headaches from time to time, but they are nothing like they were. And so that was kind of what got me into this field, kind of conservative care in general, was I was one of the few people in PT school that was like, I'm here to learn about headache and stuff like that. And as you know, that's kind of not a huge component of PT education. So between, post-grad and kind of getting into this area, taking more classes from like CRAFTA and groups like that, really kind of helped me get into this niche. And I think in addition to the personal piece, like the professional piece of, I know you know this as well, is like these cases are no case is the same. We can talk about this like from an evaluation standpoint of like, there's some symptom overlap for sure, but each case is really unique. And so it's really even more, I think, than sometimes even other areas of PT, like a collaboration standpoint of like, what can we do to help these patients to actually see improvement functionally and in their life and stuff like that. And I think that is one of the biggest things to me that keeps me excited about this area is there's so much conservative care can offer for these symptoms that often, we don't have great answers to and are certainly challenging to treat, but there's so much that we can offer and so much we can empower our patients to do to get back to their lives.
Yeah, absolutely. I love a couple of points that you made. So just kind of going over it, the lifestyle factors you mentioned, I think that's extremely important, especially in the realm of headache. It's important for any disorder, but I think when it comes to the world of the headache, especially so, even when the issue is, say, largely orthopedic, I think people have a pretty good understanding with migraine. Like if you have a migraine disorder, a neurological disorder, really sharpening those lifestyle factors is really going to make a big difference. But when it comes to chronic, say TMD or jaw dysfunction, a lot of people kind of move away from that. They think jaw pain is just much more mechanical in nature, much more orthopedic in nature. But I think chronic TMD, even though it's, the source is very orthopedic, I think it is one of those disorders where if you carry a lot of stress and carry a lot of tension, it really amplifies the pain signals from what you're dealing with. And then I also really enjoyed what you said about conservative care, finding relief with conservative care. I kind of fall in that same boat as well. I'm a chronic headache patient. I've had a headache for 7 years, new daily persistent headache. And, I've done most of the treatments, pretty much all the treatments. For me, it was also actually the real turning point was conservative care, especially with vision therapy, actually. So I think, you and I and other PTs out there, we're actually highly underutilized, especially for these complex cases. And, conservative care can really take people far, provided that they are the right, appropriate patient for what we do. So let's get a little more clinical now. So can you tell us when it comes to TMD, what does your evaluative process look like? What kind of measures are you using to track progress, and what kind of tests are you administering to direct your treatment?
Yeah, it's a great question. And kind of to go off what you were just saying too, of like with TMD particularly, I kind of get two main groups of patients with this. So the evaluation process, largely varies from there. Like a lot of PTs, I do, kind of a 60 to 75 minute evaluation process. And what's great with stuff like this is so much of this, and I know it's a cliche, of like having space for people to tell a story, to share kind of what they've experienced is so key with this. And that can help me identify what route we're going down. So for instance, if we have like someone that's coming in, it may be more of an acute scenario. So maybe it's only been a couple months that they've been having some jaw and facial pain. And usually these folks will end up, going to their dentist, and dentists may do some imaging, may do some, further evaluation and be like, well, there's nothing really wrong structurally from the tooth standpoint. And then often those patients will end up, coming to see me. Maybe they had like some sort of event. It could have been a common one I hear is like seemingly out of the blue. So I took a bite into an apple and all of a sudden I had this excruciating pain, and now my jaw motion is limited and I'm in tons of pain from here and it's starting to spread and stuff like that. So with patients like that, it does tend to be a little bit more of this standard orthopedic and mechanical presentation. So from that standpoint, we're looking at stuff like range of motion of the jaw and the neck. We're palpating. I use like the TMD inventory, which is kind of an outcome measure, which is really kind of covers all the different areas of function for the jaw. It isn't just looking at pain. And so from those patients, what we'll usually do is, get a good idea of kind of what mechanical piece may be presenting. Is it more, articular? Is it more muscular? Is there some sort of neural component as well? So that's kind of one subgroup of patients. The other is more of kind of true persistent or chronic TMD facial pain. These patients, maybe have been to 5, 10 different providers, usually dentists, oral surgeons, sometimes neurologists, and then usually have had some sort of connection to like integrative or alternative spaces. So maybe a chiropractor or acupuncturist. And those patients, when they end up, the evaluation process looks similar in some regards, but definitely a lot different. So we're looking more into kind of how is the nervous system itself processing this information. We're looking at sensitivity of kind of the areas of the trigeminal area. We're looking, as well as kind of sensory motor issues that may be going on in adjacent structures. But then also, like you said, bringing in that lifestyle component, because often people have been told like, oh, this is just stress. Do some simple breathing exercises. Love breathing exercises, but it is often more than that. So we'll look at like all the different ways that the neck, the jaw, and the face are kind of all processing information. And then finally, I'll also look a lot at kind of tongue function and stuff like that. So are patients able, like in functional activities, like swallowing, like I'll have people, take a sip of something in the office, looking at kind of how the different pieces of the system are responding to that. So you may see like often people take a sip of something and have excessive neck motion or are not engaging kind of more swallowing muscles and stuff like that.
Very, very interesting. Yeah, and then you're looking at tongue movements as well. I don't think that's something most PTs are well versed in. I think a lot of people would probably just refer those people to probably speech if they really felt like there was a major issue there. So, are you collaborating a lot with dentists? Like, are you seeing patients who kind of already have eight or orthotic splint maybe, or do you think you're more seeing people who have failed dental treatments like that?
Yeah, I mean, ideal world and the reality are often different things, but often like there's several dentists that I know in town and we have good working relationships, particularly for like our more persistent cases. The best outcomes are when there's kind of that team approach to working on some of the, more occlusional type things through, mouthpieces and stuff like that, and combining that with therapy. I mean, that clinically and from an evidence-based standpoint are going to be some of our best outcomes. That being said, I think like with any referral process, there has to be some sort of sense of shared kind of patient philosophy. Obviously, there's dentists that don't quite understand how like a conservative approach can work as well, or there are some dentists that have an overly mechanical view of facial pain. And so those can sometimes be more challenging because you're wanting to respect the practitioners that the patients are seeing, but then also having a different view of like how these present. But at the end of the day, working with the providers and the patients is going to be obviously the best case scenario.
Yeah, it's definitely a fine line. We talk a lot about interdisciplinary care, and of course, interdisciplinary care is really important. We know it leads to better outcomes, but I think you're right in that it can be a bit of a double-edged sword, because you are different providers, and different providers have different ways of seeing things. And if it's not the right person you're working with, it can backfire. I've actually had this experience myself. I had a TMD patient. He came in and he's been dealing with pretty severe TMD, chronic headaches. And, in the first session, I was able to bring that pain down probably by at least 50%. I could see the relief in his face. And then I said, maybe you should go find a dentist who could do an occlusal splint for you. And then if we could juggle that between me and them, that'd be really great. I think that would lead to the best outcomes. So he goes and sees the dentist, and it's a dentist I don't know. I'm still new to San Diego. I don't have that many connections. And the dentist who gave him the splint told him that he doesn't need physical therapy, that there's no value add to him. And what happens is, he then of course canceled the appointment with me. And I think you and I are both pretty aware that this is not best practice, right? Even if you fix the occlusion, there's a lot of motor dysfunction that happens. A lot of, I would say, like motor unlearning that happens when you're dealing with that much headache pain, especially as disabling as his was. And the dentist he saw told him to just wear the splint and let the muscles fall back into place, whatever that means. So that's just one of my stories where it's like, yeah, it's really important to develop working relationships. And I think it's okay to differ on some things, but there needs to be some overlap in treatment philosophy, like you said. So obviously every case is very different, and we don't have time to discuss all treatment interventions, but could you tell us about like a particularly interesting case you've had? Like what treatment techniques did you use and why? And what was the patient's recovery like?
Yeah. So one patient comes to mind specifically. Patient had a onset of kind of jaw pain, which often happens kind of after some dental work. And so this is she had about a year or so of this. So often, as like we've talked about already, had been to tons of different providers. Everyone had kind of a different answer. And we know how frustrating this is for patients when you're wanting to find relief and can't get even, going to medical providers and, one person saying this, one person saying that. So saw her, did a evaluation, saw that there was just a lot of kind of trigeminal sensitivity that was also referring into headaches, was also having some more autonomic symptoms as well of kind of, ipsilateral kind of sensitivity, some redness, sweating, stuff like that. Obviously, she'd been ruled out for anything crazy by this point. And so from an evaluation standpoint, one of the things that was most evident from our initial eval is the sensitivity was so much near the jaw that the patient didn't want me to touch that area, and said it had been a while since like a healthcare provider had kind of even palpated there. So we kind of talked about like that, and I gave her a lot of information, sort of like we talked about earlier, about like kind of the convergence of the nervous system through the trigeminal cervical complex. And so the first session, I did no specific TMD work. We actually just did some desensitization techniques, kind of sustained pressure techniques at C2, C3. And that actually did help to kind of bring down some of those symptoms on day one. And so
are you doing like glides or joint mobilizations with those sustained pressures, or is it more like pressing on sore spots? Okay, gotcha.
Yeah. So I typically like a kind of a lateral glide at C2, C3. I'll do that sometimes. Then I'll do a little bit more as well of kind of like a Dean Watson technique of kind of sustained pressure with reproduction and resolution of symptoms. But for this patient particularly, it was more just of doing some lateral glides, very gentle, grade 2, grade 1 even, of these glides. And so just aiming to get some sort of relief. And we were able to get some reduction in symptoms day 1. But what was really important for this patient on day 1 too was just the education. And as you know, as a practice owner, education is one of our most powerful tools. It's sometimes really hard to like market that to a patient, before coming in. We talked about like kind of all the neurological connections. We talked about kind of some of the like explained pain type concepts of like central sensitization and spreading. And it was one of the first times the patient said that like someone was able to provide some sort of framework within which to see her symptoms. So we've been working on that, and through manual therapy and just some kind of gentle, graded exposure exercises at home, starting with just very simple things like tongue movements while keeping the jaw stable, teaching her how to do some cervical manual therapy at home to kind of help with symptoms if things do get a little flared up. And over the course of about a month or two, we've really kind of moved into more of kind of some sensory motor training. So I know you know this, but often with like persistent pain, there can be something we call cortical smudging, where the brain's map just gets a little distorted. And she was definitely showing some signs of that. So we've done like some sensory motor retraining, essentially like having her close her eyes while I press, touch different areas, having her like match that with a numerical value to kind of work on kind of reorganizing some of that sensory response. And we've seen improvement with that. But I think the biggest thing for this patient too loves to travel, was afraid of going on a trip with their partner because of these pain symptoms. And through kind of the education and through the work that she put in, was most recently able to go on a trip to the Keys and reported, not that the pain wasn't there ever, nothing that pain was stopping her from doing. So those are just great examples of like, with stuff like this, of how it is that we want to frame it to a patient of like, what can we do? What can we get you back to doing?
Did she have any dizziness at all with her jaw pain, or not too much?
Not too much, but
okay.
Yeah, not too much with that.
Okay, yeah. So jaw pain is very interesting that I think people are often surprised that when it can result in dizziness as well as tinnitus or ear ringing, but that's just kind of going back to the trigeminal cervical complex you talked about. There's a lot of overlap in where these nerves kind of converge, and if a signal is really loud from one, it can kind of bleed into these other systems, which is why we get these symptoms. That's absolutely amazing what you're talking about. It does sound like a complex case. It sounds like there was, the jaw was a major contributor, but there was a little more to it than that. You were talking about the kind of trigeminal involvement with the autonomic nervous system dysfunction, right? So that sounds, obviously I can't really say, I don't know the patient, but that sounds to me like there is kind of a migrainous component to what she was dealing with. And then just for our listeners, I think for those who aren't familiar with facial pain disorders, one way I think that's really easy to spot a facial pain disorder is listening for autonomic dysfunction of the head or neck. So oftentimes with our patients, we hear things like sinus congestion, we hear things like, eye tearing, we hear things about ptosis. These are all things that we see with our headache patients, and when you do see that, you can automatically pretty much flag that as some kind of autonomic nervous system dysfunction. Yeah. So this is a endlessly fascinating topic. I know you and I could probably talk about this for hours and hours, and thank you for being on the pod. And so can you tell us, where can people find you?
Yeah, I am moderately available on Instagram, depending on my schedule and stuff like that. But you can find me on Instagram at Gate City Physio, and also my website. I think you're going to link that in the show notes. But yeah, thanks for having me on, Jimmy. I really appreciate the work you're doing with this podcast and kind of bringing more awareness to how conservative care can help in these areas.
Okay, great. Yeah, so for our listeners, definitely check out his Instagram. There's really great educational information on there, as well as his website. And then if you enjoy listening to this episode, please consider leaving us a 5-star review. It really helps us get this message across to the right people. Thank you so much, Dr. Corey Hillman.
Yeah, thanks, Jimmy.